So just a brief word about epilepsy monitoring units and safety. We're very lucky in Glasgow to have a 4-bedded unit with excellent history of safety. The main worry when it comes to epilepsy monitoring units is the incidence of SUDEP, and we know from the Mortimer retrospective study of monitoring units that the SUDEP rates are around 1 in 10,000 video EEG monitorings. So very rare, but very important, and in particular, nocturnal bilateral tonic-clonic seizures. Patients in a prone sleeping position seem to be specifically the ones at risk. And the monitoring units have criteria for EEG monitoring, ECG monitoring, and this being visible to dedicated, trained nursing staff who can respond quickly within 30 seconds of a seizure occurring in order to avoid adverse events. So medication reduction does allow an increase in seizure propagation without changing the seizure onset zone, so it's a delicate balance when you're bringing a patient in for seizure monitoring with regard to medication reduction, increasing the risk of bilateral tonic-clonic seizures whilst producing an EEG yield during a short admission, and preferably just one admission. So you're trying to increase the rates of seizure induction without increasing the risk of harm to the patient. We know that 7% of admissions will suffer an adverse event of some description. The risks are very specific to the individual: falls, osteopenia causing fractures, post-ictal psychosis, and in particular patients with previous status epilepticus would be the ones to worry about, and the ones with a long duration, so young patients with a long duration of treatment-resistant epilepsy and recurrent generalized tonic-clonic seizures. It doesn't actually need to be that frequent, just more than 10 generalized seizures within a year puts that risk up. So the important aspect of this, from our perspective, if we are inducing this risk, is to obtain explicit written consent, ideally having previously discussed these risks and the risks particular to that patient in clinic, so that the patient's prepared to come in and sign a written consent form. There should be an individualised anti-seizure medication reduction plan for that patient, designed by the consultant responsible, and that will vary from person to person. Usually the seizure medications, anti-seizure medications, are reduced at the time of admission. The only ones that you consider reducing beforehand are the ones with a very long half-life, such as zonisamide or perampanel, but the rest, in general, it's done at the time. The usual plan is a relatively rapid reduction in dose, so 50% day 1, possibly 75% day 2, and that produces quite a good seizure yield. There have been randomized trials of slow reduction versus rapid reduction, slow being 15 to 30% reduction in seizure medication compared with greater than 30%. And predictably, in the more rapid reduction, there are higher rates of 4-hour seizure clusters necessitating benzodiazepine rescue medication. And there should be a clear written protocol for that patient, again designed by the consultant, stating the rescue benzodiazepine, and usually plus a 24-hour dose of anti-seizure medication should seizures occur. And I can commend this paper to you, which is Jack, one of our previous trainees, a very useful table called the Patsalis table, looking at interactions, pharmacokinetic interactions, and advising if you're interested. But that's more specific, I suppose, to the epilepsy consultant. And here, when you have patients who are having more than 2 seizures a week, in any case, you generally won't require any medication reduction completely to increase their risk of harm. So just a comment about that, and a reminder to get explicit consent and the patients to worry about the ones with the rapid reduction in anti-seizure medications and previous